You're listening to Medscape's In-Discussion series on metabolic dysfunction-associated steatotic liver disease, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Drs VanWagner, Associate Professor of Internal Medicine at UT Southwestern Medical Center and Director of Digestive and Liver Diseases Clinical Research and the Internal Medicine Clinical Scientist Training Program. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers.
Hello, I am Dr. Drs VanWagner, an associate professor here at the University of Texas Southwestern Medical Center in Dallas, Texas. I want to welcome you to Medscape's In Discussion series on MASLD. Today, we're going to discuss mixed causes of a fatty liver and how to understand them with our guest, Dr. Drs Ajmera. Dr. Ajmera is an associate professor of medicine in the Division of Gastroenterology and Hepatology at the University of California, San Diego School of Medicine, where he is a fellow transplant hepatologist, and he is also a leading clinical researcher in MASLD and advanced liver disease. So I'm so excited to have him as a guest today, and I welcome you all to In Discussion. Viral, thanks so much for being here. I really appreciate it.
Thanks, Lisa. Appreciate the invitation.
I was just in clinic yesterday, saw a patient. It was a 35-year-old who was referred to me for elevated liver chemistries and had a fatty liver on their ultrasound. And when I asked him about his alcohol use, he told me that he drinks maybe a few drinks, nothing major. When you hear that phrasing from a patient, a few drinks, what goes through your mind clinically?
The first goal is to try and go from an ambiguous sort of description to more detailed, specific quantification of alcohol intake. So in the actual clinic visit, I try to just use interviewing to get more specificity. So when you say you have a few drinks, what do you like to drink? Is it beer? Is it wine? Is it cocktails or shots? And then I try to get to quantification. We know how many grams of alcohol are in a standard drink, and I'm trying to get to an understanding of that by just quantifying it for the patient. So when they say, I have a couple glasses of wine, it's important to know that that could be variable for different patients. So a glass could be a pretty heavy pour rather than a standard pour. And so I say, oh, well, do you finish a bottle of wine then, with whoever you're drinking with when you're saying you're having 1 to 2 glasses? Maybe that indicates that you're drinking much more than that. And so I try to equate what they say they're drinking to standard drinks, but in a conversational format. That helps me truly understand. And then I try and understand frequency and patterns. So is it daily drinking? Is it after work? I always have a few cocktails. Is it more of a binge pattern of drinking on weekends or other specific days? So I try to get from that ambiguous statement to a quantification of frequency and quantity that I can equate to, potential impact on their overall health.
That's so unbelievably important. I love your framework to do it in a conversational approach. It's a sensitive topic, I think, too, for many patients, and I love that approach. So when you're doing that quantification, maybe you could just take us through a little bit in your head. What then, once you've done that quantification, raises your red flags that alcohol may be a major driver?
Yeah, so the patient we know already has steatotic liver disease. That's the indication for the referral. And we've known each other for a long time, Lisa, and we were just talking about how we've been collaborating on research for over a decade. And one of the first papers that I wrote, it was about a decade ago that I started working on it using NASH CRN data, because many moons ago, people thought that moderate alcohol use was actually beneficial in steatotic liver disease, right? And there was cross-sectional data, and there's a lot of confounding. And we even wrote a review in hepatology looking at all the different confounding factors between modest alcohol use or moderate alcohol use that could be impacting some of the reasons that cross-sectional studies were showing benefit. But I think the key thing that I want to highlight is moderate alcohol use, even within the bounds of what we call or is consistent with MASLD, likely impedes your ability to improve at the very least. That's what we showed, and may exacerbate disease. And so any amount of alcohol is relevant. And then we have to think about it in the context ultimately, and I know you've had other conversations about how active is their disease and what stage of fibrosis does a patient potentially have.
Yeah.
Because the counseling that I provide a patient is very different. If you have significant fibrosis, there's no amount of alcohol that is safe and that you can continue to consume. So that's stage 2, 3, 4 fibrosis. Certainly our cirrhotic patients, I'm surprised sometimes to see that modest alcohol use is not discussed more thoroughly with patients with more advanced fibrotic liver disease, because in that case, the synergistic harm is really significant. So I think for all MASLD patients, discussions about alcohol and harm reduction are important. And so after I quantify the alcohol use, I typically tell them if I know their fibrosis stage to be mild or none, that there's no clear benefit from ongoing alcohol use. Certainly, there's a caloric intake associated with it. You may be consuming 200 to 300 calories with no real nutritional value, which is impeding your ability to lose weight. Finally, that the data at least shows, even with mild disease, that it impedes your ability to improve with all the lifestyle measures that we encourage and other factors. So I try to contextualize it for the individual patient. If you don't have no fibrosis and you want to have a glass of champagne on special occasions, I try to be practical in terms of my counseling. But I do want them to understand the data and know that even very modest amounts of regular alcohol intake can have a negative impact in patients with steatotic liver disease.
I love that. I love that. We sounds like we have really similar approaches. And I definitely use this is for sure impeding the weight loss efforts that we just talked about, right? That's a big one. Empty calories in that can of beer or that glass of wine. One of the concepts that's come up in the last couple of years, and actually in the last 3 years, right, is this new terminology that we have in steatotic liver diseases that we now have a name for, MetALD. Can you explain to us what MetALD is and what do we know about it thus far?
I think we've all known that this entity exists for a long time, and it just didn't have the appropriate nomenclature. And so changing the name doesn't mean that it didn't exist forever. It's always a diagnosis that has existed, but it helps us study it, it helps us understand it, and then it helps us prioritize multiple domains of harm reduction for patients and counseling. So really the diagnosis is that you have a component of a metabolic dysfunction contributing and driving your steatotic liver disease. And the alcohol is also another major component contributing to your steatotic liver disease and your risk of disease progression. And you'll talk to some people that say almost all SLD is MetALD, even if they have alcohol-associated liver disease, alcohol predominant in the United States. If we look at adults, a very large percentage of them have a cardiometabolic comorbidity that may be contributing. And then on the other end, we just talked about how even within the bounds of alcohol use that's still defined as MASLD, let's say, less than 2 drinks per day on average for women or less than 3 drinks per day for men, or if we want to quantify it in grams of alcohol, it's a little more stringent, but less than 10 drinks per week for women. Both domains are important across the board. In this MetALD, they're both significant contributors. And you can even have alcohol predominant or metabolic dysfunction predominant, but it's a recognition of that's a unique entity where both things are contributing. Previously, we kind of had these people in a gray zone where they didn't meet the diagnosis of MASLD, but we knew alcohol was contributing, but it perhaps wasn't as high as our typical alcohol-associated liver disease diagnosis. So now that we've defined it, I think we're seeing that it's not an infrequent diagnosis.
Yeah.
And that in addition, perhaps these people have a little bit more of an accelerated disease progression compared to our standard MASLD population. And so it's an important population. And then we think about diagnostics and therapeutics, and we can chat more about that as well.
I think that's super important. I think one of the most interesting trends I've seen in the literature since we now have this name, like you said, it helps us to quantify, study it, understand the natural history of this population, is also this concept among steatotic liver diseases when we think about diagnosing someone with MASLD or ALD or MetALD, that diagnosis is dynamic because it's based on risk factors, and risk factors change over time. Alcohol use changes over time, right? Like seasonality, depending on when you see somebody in clinic on a Monday versus you see them on a Friday, right? What their alcohol uses may change. It's been really interesting to me to understand the ups and downs of when I assess alcohol use in a patient or metabolic risk in a patient, that what I might call them at that point in time might actually change, which is super interesting.
Yeah, I think that's a great point. And I definitely think this is something that is of great interest to all of us in terms of when we think about therapeutics and designing studies to treat MetALD, the fact that 1 week you could be MetALD and then 6 months later you could be MASLD, depending on how long we're defining the category, and the assignment. And so that's certainly a challenge. And I think that's where getting a sense of lifetime alcohol intake
Yeah.
and patterns over a longer period of time is really important in that first clinic visit. Understanding what factors may trigger increased alcohol intake and then how to address it. It's certainly very dynamic, and that's why focusing on both the metabolic and the alcohol at every visit is really important because the alcohol intake may be decreasing, but then if you still haven't addressed the metabolic components, they could still have disease progression or vice versa.
Yeah, super important. Are there tools that you're using in clinical practice to, I think, maybe more systematically or objectively over time assess alcohol use in your patient population?
Definitely. I think there's both interview-based tools and then there's biochemical tools, and we use both. I think for hepatologists, and I hope that we continue to disseminate the utilization of PEth, phosphatidylethanol testing, which is an extremely accurate biomarker of alcohol intake. Typically over the last 2 to 4 weeks, it sort of integrates intake. And so we do use that, and now there are a number of studies that have shown that many patients who we thought had MASLD actually likely reclassify to Met ALD or even ALD.
Yeah.
Of course, it takes time to build a therapeutic relationship. There's a lot of stigma around reporting alcohol use, and so patients may not be as forthright. What I find is that I tell patients that I'm going to obtain this lab test that'll give me a sense of your cumulative alcohol intake over the last 2 to 4 weeks and how it may be impacting your body and contributing to your liver disease. And I've never had a patient say, don't draw that lab on me.
Yeah.
We draw it systematically in patients who are being evaluated for liver transplant and after transplant, right, to evaluate for return to harmful drinking or slips. And so that test has been transformative. And I think certainly it has helped me identify patients who have harmful drinking and has also helped me then counsel them. Patients have been more willing to accept, okay, now we're on the same page and maybe it is more than I thought it was. There may be cognitive blocks to even admitting that this helps open up. And then systematically, I think from a practical perspective, Audit C is a really quick screen that can be integrated. It's integrated into all of the notes from our fatty liver clinic or steatotic liver disease clinic. Even though we think we're seeing MASLD, that screen is integrated and 4 questions can be instructive. I essentially ask those questions in my conversational interview with the patient, but it's structured also, right? And you can calculate it. And even an MA or someone who's helping you room the patient can get that data for you and put it into the chart, and then you can look at that screen and have a sense. So that's I think 2 extremely high yield. From a clinical Pearl perspective, typically in MASLD, unless they're cirrhotic, one would not expect to see the AST higher than the ALT. And so if I see that, that alerts me, okay, now either this patient may have more advanced liver disease or there may be a greater component of alcohol intake. That's, I think, certainly another clue. And then we often see patients who don't necessarily have significant cardiometabolic complications and or are lean and have steatotic liver disease, and they're reported to not have any alcohol intake. That's another situation in which certainly we want to think about objectively quantifying the alcohol intake to be sure that we have the right diagnosis.
Those are so great. And one thing you said I love is that PEth testing may help to remove or help people to sort of recognize that sort of cognitive block that somebody has about alcohol use. And I know when I've lectured on this topic, I talk a lot about we all underestimate everything that we take in,
Yeah.
right? So
Yeah.
food diaries are underestimated versus the pictures that you take of food, of patients take of clinical studies. We underestimate our portion sizes, caloric intake. So I know one of the things that I've started talking to with patients about is I sort of call it one of my other liver vital signs, right?
Yeah.
I weigh you in clinic and I calculate your body mass index and I get your blood pressure and we measure your hemoglobin A1C and diabetes. And this is like the hemoglobin A1C of alcohol intake, right? It's an average and it gives me information that helps me be a better liver doctor.
Yeah. Are there specific populations of patients in whom you check PEth, or are you checking it systematically in all of your referrals for steatotic liver disease? What's your approach?
Yeah, that's a great question. I actually have shifted to using it systematically. I know a question that may come up from primary care providers is cost effectiveness of doing that. I do want to clarify that I think our clinical practice guidelines and care pathways certainly recommend its use or consider its use in specialty clinics. I don't think there's great data for systematic population-wide use of PEth testing from a cost-effectiveness standpoint, at least across the board. But in liver disease clinics, our clinics, where there's a pretest probability for more advanced disease because of the types of patients that are referred to us, I think that alcohol is such an unbelievably important cofactor in my ability to manage that disease that I am systematically checking it pretty much across the board.
Yeah, I totally agree with you. And I think this is variable across even specialty
Yeah.
practices. For me, I agree. If somewhere around a quarter of the patients we see have significant fibrosis, let's say in a specialty clinic for steatotic liver disease, and if the amount of disease reclassification is anywhere from like 15 to even 30% or a third of patients, then you have a significant tool in terms of harm reduction. Now we have medications for patients with alcohol use disorder that we're integrating into our practice, certainly more routinely. So we have all these tools, and we know that it's a major driver of liver-related outcomes in the longer term. Let's say the test is about $100. I mean, it's going to be variable. U.S. healthcare is complicated. So I think that we certainly need to study cost effectiveness, and you have to think about the population. But for a specialty population with steatotic liver disease, I think it's a high yield test. And we often test for zebras with our ceruloplasmin and a 55-year-old where we're not going to find Wilson's. And to me, it's crazy that that test probably costs $60 to send out, and a PEth where we may find 1 in 4 patients actually underreported alcohol. We're reluctant to send because of cost effectiveness. So I think it's a great test. I totally agree. And the primary care or broader population, maybe you reserve it for some of the populations I just mentioned, where AST is higher than ALT and they're not necessarily reporting
Yep.
significant alcohol use. They have steatotic liver disease, or you have a lean patient without significant cardiometabolic comorbidities who has hepatic steatosis, elevated liver tests. And again, they're underreporting. If they're already reporting substantial alcohol intake,
Yeah.
then there's not a real diagnostic utility to the PEth, although sometimes patients, just like they see their hemoglobin A1C come down, like to see a number come down
Yeah.
to show that their efforts are measurable and are having an impact. But I don't know that you need to really use an expensive test for that. You could probably track their liver tests or something like that.
Yeah. No, that's a really great point. Maybe since we're on the topic just a little bit, I'll ask 2 sort of practical questions. If I was a primary care doctor, number 1, anything I need to consider if I was going to send a PEth test to like clinical scenarios where are there false positives with this? How does this compare to blood ethanol level, where it could be from the alcohol that's drawn on the skin? And then how do you send the test?
Yeah, it's an extremely accurate test. The situations in which we deeply explore false positives are transplant because it's a very high stakes situation when you have a positive path. Most of the path cutoffs that are utilized are 20.
Mhm.
It's an LCMS test, so it's a send out and it's a very accurate test. And there's 2 different homologs that are often tested. Oftentimes they're using that 20 cut point, and they say if it's under 20 or between 10 and 20, it could be mild or no alcohol use. Above 20 typically is an indicator that there's some modest alcohol use at least. The instances in which we've considered false positives are particularly significant transfusion,
Yeah.
right? Because you've gotten someone else's blood, you don't know what their alcohol intake is. There's even one case where a patient was referred to us for transplant, and they had historically alcohol associated liver disease, but they'd received massive transfusion and their PEth was a little bit elevated, and the referring physician actually had the blood bank test PEth on the donor blood.
Oh, wow.
They had some existing samples, and it was elevated, and to justify it, because he's like, this patient couldn't have. But these are really edge cases. Otherwise, I'd say it's an extremely accurate test in my experience, and very few other causes for potential false positives. So I typically make sure they haven't received massive blood transfusion or significant transfusion if there's a mild positive. And I repeat it if there's especially a high stakes decision to be made around that. And because it integrates typically 2 to 4 weeks, if it was elevated, it's not like a blood ethanol level where it's just reflecting active alcohol in one system. It's integrating over 2 to 4 weeks. So repeating it again should mitigate if there was some test variability. But it's a very accurate test. And I think that's the one context I think about false positives.
Awesome. Well, this is so helpful, Viral. I want to thank you so much for your time today and give you an opportunity. If there is one thing that you would like primary care doctors to take away about the role of alcohol in steatotic liver disease, what would that be?
It would be that alcohol affects steatotic liver disease across the full spectrum. So if you diagnose someone with MASLD, even if their alcohol intake is below thresholds that would be met ALD or ALD, the alcohol intake is still important. It's important from the caloric component. It's important from potentially impeding their ability to improve from their MASLD. And it's dynamic, like you talked about, Lisa. And so you may be seeing them with MASLD now, but it may be met ALD levels of consumption at other times. We have really great tools for harm reduction between motivational interviewing and now pharmacologic therapy. And so I think in terms of the whole spectrum of steatotic liver disease, both the metabolic components and the alcohol really should be the focus. And one may be a more significant driver at a specific time point, but it could change. And so we should be keeping our guard up and trying to objectively understand it, and then working with the patients on harm reduction.
Awesome. Well, thank you so much, Dr. Ajmera, about helping us better understand the role of alcohol in fatty liver disease. I think you've heard loud and clear today that we have to ask and we have to quantify alcohol use. MASLD and alcohol frequently coexist, and even moderate alcohol use can worsen liver injury, especially in patients with metabolic risk factors. There is no clear safe level of alcohol use in MASLD, and certainly not in patients with stage 2 or greater fibrosis. And the framing really matters. We have to approach this from a non-judgmental, patient-centered, conversational space, as Dr. Ajmera pointed out. So I want to thank you all so much for joining us. This is Dr. Lisa VanWagner for In Discussion.
Thanks for listening to Medscape's In Discussion Metabolic Dysfunction Associated Steatotic Liver Disease podcast series with our host, Dr. Lisa VanWagner. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on metabolic dysfunction associated steatotic liver disease.